in last 5 years, there is a new trend that molecular basis of carcinoma, especially the colorectal carcinoma, is coming as a long question. There is a beautiful question regarding the Adenoma-Carcinoma sequence in case of colorectal carcinoma. And you of course should expect at least one short note from this topic. It's not only an important topic for your theory purpose, but also in your practical. You will get a mounted specimen in our department and also a microscopic specimen. So anyway, I should start this. If you consider different kind of neoplasm in colorectal region, then broadly that can be divided in benign and malignant condition. So benign tumors in colorectal region, starting from the ileocecal valve up to the anus, is not that area, colorectal region. And in this area, basically the tumors can be divided in broad two categories. One is benign, one is malignant. And of course, all kind of benign tumors are not transformed into malignant one. Only some segment of benign tumors are transformed into malignant one, and those are basically the adenomatous polypoid lesion. So before going to the subject, that is colorectal carcinoma per se, I have to mention some points about the benign tumor. So first, what are the benign tumors? Whenever there is any kind of projection, any tumors which is lined by epithelial lining in all direction, it is known as polyp. Is it not? What is polyp? Any tumor which is lined in all direction by, at least in 3 direction, by epithelial lining, that is known as polyp. So mostly these are basically some kind of polyp. Polyps are broadly classified into 2 categories. One is adenomatous polyp and others are mainly hyperplastic polyp or inflammatory polyp. You can consider this hyperplastic and inflammatory polyp to be non-neoplastic one, but adenomatous polyps are very notorious for the transformation of neoplastic ones. Okay. Broadly, these adenomatous polyps are of usually 90% cases and 10% cases are inflammatory and hyperplastic polyp. And histopathologically, this adenomatous polyp can be divided into mainly 2 categories. One is tubular structure, depending upon the histological structure, that could be tubular adenoma or that could be villous adenoma. Okay. Histologically, that adenomatous polyp can be divided into tubular adenoma and villous adenoma. There might be some kind of mixture between these two, that is known as tubular villous adenoma, but and that portion is also in a very great number, but for your standard you have to identify this type of these 2 morphological structure. One is tubular, one is villous. As the name suggests, that tubule means those cryptic structure, those glandular crypts, nothing but the accumulation of glandular crypts. There is nothing like any villi kind of structure. All of you I think know what is the villi. All of you know. This malignant villus like structure is not evident in case of tubular adenoma. You can see these crypts are accumulated. These are complex cryptic structure, isn't it? It is villous adenoma and it is about 20% cases of adenomatous polyp. And the second one is villous adenoma. Usually in case of villous adenoma, there might have some kind of stalk. So any polyp, if any polyp having a stalk, this is known as pedunculated polyp. Grossly, the polyp can be divided into 2 types. One is pedunculated polyp, one is serrated polyp. And histologically, that is under microscope, can be divided into 2 types. One is tubular polyp, one is villous polyp. Get my point? So what is pedunculated polyp? Any polyp which has a projection. So if the polyp has a projection from a surface, that means they should have a stalk. Okay, and these villous polyp usually have such kind of stalk. So villous polyp are morphologically, I mean in gross, they are pedunculated one. Get my point? Are you clear with that? And tubular villous polyp might be such. So in morphology, you can see there is so many villi-like structure. Of course, they have some kind of dysplasia, some kind of atypical structures, and that is some kind of atypia present in the lining epithelium of this kind of villi, but they have a stalk. They have a stalk, and these are villous adenoma. So basically, what I am telling that these are basically dysplastic polyp, and depending upon the number and which type of morphology is present, the amount of, that is the degree of transformation into the neoplastic changes are different. Like in case of the villous adenoma, there is 5% chance of transformation in the malignant one, and in case of the tubular villous adenoma, there is 22% cases, and in case of villous adenoma, it was 40% cases. Usually those polyps which are less than 1 centimeter, they have a little bit of lower chances of transformation into carcinoma, that is invasion. You all know what is the difference between the carcinoma in situ and carcinoma proper, that is invasive carcinoma, that is loss of basement membrane. So if the polyp is less than 1 centimeter, there is lesser chance of local invasion. If the size of the polyp is more than 1 centimeter, there is higher chance of local invasion. So keeping these points in your mind, you just have to go into proper colorectal carcinoma. See, there is a stalk. Stalk means it has a core, fibrovascular core, and around the fibrovascular core there is arborizing pattern of villi-like structures, and all these villi are lined by some kind of epithelium. Lining epithelium has some dysplastic features, some kind of all type of dysplastic features. You all know what are the key features of dysplasia: high NC ratio, anisonucleosis, nucleomegaly, prominent chromatin. Yes. So this kind of dysplasia is present. Any adenomatous polyp have some kind of features of dysplasia because they are very prone to develop carcinoma. Usually you can get, now this is kind of serrated polyp. Usually the serrated polyps are benign. Usually serrated polyps means they have a very flat surface. They don't have any stalk. There is a growth or protrusion over the epithelium, and it is basically a flat top type of organization. So this is serrated polyp. Anyway, there is 3 familial condition with which the colorectal carcinoma is associated. One is regardedly known as Familial Adenomatous Polyp. Second condition is known as Lynch Syndrome, that is HNPCC, and third is Familial Colorectal Syndrome. So first is very important, it is known as Familial Adenomatous Polyp. You can expect one short note from this. So what is FAP? Have you heard this name FAP? Familial Adenomatous Polyp? Okay. This is an autosomal dominant condition, and 1% of all colorectal carcinoma associated with this syndrome. Why it is syndrome? Because there is a germline mutation of one tumor suppressor gene which is known as APC gene, and that mutation of APC gene, which is located at the chromosome number 5, that is the long hard arm of the chromosome number 5, there will be APC gene, and any germline mutation affecting the APC gene associated with that familial condition. Okay, and it runs in family. If there is a person is affected in a family, there is 25% chance that it will project, it will be present in the next generation. And usually in case of familial adenomatous polyp, there is more than 100, at least 100 polyps is present throughout the segment of the colorectal region, throughout the segment. Usually that number is 100 to 1000, 100 to 1000. And another very important point is, when a person approaches to the age of 50, there is 100% chance that those polyps transformed into colorectal carcinoma. So whenever there is any member in the family is affected by familial adenomatous polyposis syndrome, there is of course autosomal dominant cases. So 25% chance that in the next generation you will get some kind of FAP, and of course when the FAP is present, by the age of 50, they eventually develop the colorectal carcinoma. Two distinct phenomena is associated with this because they have some kind of extra intestinal or extra colonic manifestation. One is known as Gardner syndrome and another is known as Turcot syndrome. And not only it develop some kind of polyps in colorectal region, but also in the duodenum, especially in the first part of the duodenum. And eventually from this polyp in the duodenum, they develop periampullary carcinoma. Periampullary carcinoma. And nowadays, from 2010 onwards in America, there is a routine screening program that flexible colonoscopy or flexible or rigid sigmoidoscopy has to be done to see whether there is any kind of polyp or genetic mutational study should be done. That should be started at least 25 to 30 years of age, or at the age when the first generation, that is one member of the family, is diagnosed with FAP, and at least 1 to 2 years before that age. Like if my sister having that kind of FAP and that was diagnosed in 25 years, my son should start that surveillance program at least 1 to 3 years before. মানে আমার বাচ্চা যখন 20-22 মতন এজ হবে, that surveillance program should be started. Okay, so this all about FAP. And the second syndrome is Lynch syndrome. Another name is hereditary non-polyposis colon cancer. It's more common than FAP, and there is germline mutation of something else which are associated with base excision repair abnormality, that is DNA mismatch repair abnormality. They have a germline kind of mutation. It's also an autosomal dominant condition, and apart from the colorectal region involvement, it shows so many extra intestinal, extra colonic manifestation. Like it also develops carcinoma in endometrial region, in ovary, in pancreas, in stomach, in small bowel, biliary and urinary tract. So it's very difficult to, it is a syndromic approach. It's not only a particular syndrome is involved, and there is some kind of mutation, germline mutation, which affects the DNA mismatch repair. And recommended screening for colonoscopy should be started either at the age of 20 to 25, or here is 10 years younger than the youngest age at the diagnosis of the family, whichever is coming first. এখানে the screening procedure should be started by the age of 20 to 25 years, or at least 10 years younger than the youngest age at the diagnosis of the family. Okay, so please keep these points in your mind. Third is familial colorectal cancer. It's not syndromic, but it might be affected in case of 10 to 20% of all colorectal carcinoma. And there is two distinct set of, this is more common, this is the most common type. If it is a syndrome, if it is familial syndrome, then it is the most common type, and there is two distinct set of genetic mutation which are affected in case of familial colorectal cancer. What are they? These are these two mutation pathway, and among them the most important for you is APC or beta-catenin mutation pathway, which is popularly known as conventional adenoma or Adenoma-Carcinoma Sequence pathway. This question is very, 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 very important for you. It is seen mostly in case of left-sided colonic carcinoma, left-sided colorectal carcinoma, and with the start of this procedure, there is some kind of germline mutation which already present in case of neonates. They are harboring from their ancestors, and second hit was occurring after the birth. Have you all heard about that Knudsen hypothesis? শুনেছো তোমরা Knudsen hypothesis কাকে বলে? Two hit hypothesis physiology-তে পড়েছো, আমাদের genetics-এ পড়েছো? Yes, the prime example is retinoblastoma, osteosarcoma. There is two hit. One hit matlab there is some kind of loss of heterogeneity of a particular loci. The gene has two loci, you all know. In two chromosomes there is two loci for a gene. One abnormality occurring before the birth, and the child is harboring that abnormality, that mutation, and over on the top of that mutation, the second mutation occurring after the birth. So that loss of heterozygosity, the loss of heterogeneity, the loss of homogeneity, that becomes heterogeneous, is the basis of Adenoma-Carcinoma sequence. Why this loss is occurring? This is due to the loss of tumor suppressor gene that is known as APC gene. So initially there is normal mucosa. Before the birth there is mutation occurring in a single loci of APC gene. After the birth, when that loss of APC gene again in the another loci, that causing the loss of homogeneity, and that becomes the initiation of adenoma formation. So initially the normal lining of epithelium is at risk, they are at stake, and whenever there is second hit of that another loci, that causes the activation of what? Activation of beta-catenin nuclear translocation pathway, which in turn activate the MYC gene and cyclin day1, and there is over cell population, unregulated cell population, and whenever there is unregulated cell population, the mass will gather, that will form some kind of crypts, accumulation of disorganized crypts. So ultimately that will cause what? That polyp, that adenomatous polyp. Okay. So see, first there is loss of heterogeneity due to the APC or beta-catenin mutation, and the normal epithelium after two hit converted into dysplastic epithelium. বুঝেছো ব্যাপারটা কি ছিল? ইনিশিয়ালি জন্মের আগেই একটা লোসাই, জিনের একটা লোসাই অলরেডি একটা ফ্যামিলিয়াল কজ ছিল, সেখান থেকেই এটা ট্রান্সফর্ম হয়েছে, তো একটা লোসার অলরেডি মিউটেশন ছিল। আফটার বার্থ আরেকটা লোসাই এটার মিউটেশন হলো, and that causing the loss of heterogeneity, and due to the loss of heterogeneity, that normal epithelium which are at risk, they converted into dysplastic one, and gradually due to the unregulated cell proliferation, they convert into some kind of adenomatous polyp. Okay, now after that there is second mutation. Which mutation? There is point mutation of K-RAS. See, in case of dysplastic epithelium, there is some kind of point mutation, and that point mutation actually causing that dysplasia over the adenoma. Dysplasia over the adenoma. That is might be tubular adenoma and villous adenoma, and that dysplasia causing piling up, that is the chances, it causing the procurement of invasion. Why? Because on top of that, in third time, there will be some kind of deletion of DCC gene, which is present in the long arm of chromosome 18, and it basically causes the invasion. Invasion is caused by due to the deletion of DCC gene. So after the formation of late adenoma, that is the highly dysplastic adenoma, there will be some kind of DCC mutation. DCC mutation causing so many alteration of the metabolic pathway in the lower halves, and it causing the invasion in the local site. And ultimately at last there will be some kind of TP53 mutation. TP53 mutation occur at last, it occurs at 70 to 80% cases, and that causing the metastatic carcinoma, metastatic cancer. So initially there is a flat lining epithelium which are at stick. Over that there will be some kind of APC mutation which initiates the formation of adenoma. Over the adenoma there will be point mutation of the K-RAS, which actually augments the procedure of the dysplasia. Ultimately there will be deletion of DCC gene, which causes the breakage of that dysplastic epithelium, breakage of basement membrane, and that dysplastic epithelium going to local stroma, so that causing the invasion that initiate the process of carcinoma, and ultimately there will be TP53 mutation which extend that process, and there will be some kind of metastasis. Point বুঝেছো? হ্যাঁ বললে হবে না, প্রত্যেকটা পয়েন্ট বুঝেছো, এটা লিখতে হবে। অনলি এই চারটে পয়েন্টের উপরে 10 মার্কস থেকে কোশ্চেন আসবে, অনলি এই চারটে পয়েন্ট। you have to write these things, you have to write in a very pictorial presentation. That should have some pictorial presentation. Normal stretch of epithelium, over that there is some kind of dysplasia, and then there will be adenoma formation. That adenoma transform into dysplastic adenomatous polypoid lesion, and over that there should be some kind of invasion extend into the metastatic carcinoma. And 4 steps you have to mention clearly. It's very, very important. It's known as Adenoma-Carcinoma Sequence. Okay. Next set of mutational process. This process is, you don't have to remember everything, only some points. It's usually seen in 10 to 15% cases of colonic region. Usually it is seen in case of the left-sided colon. It caused due to the loss of the DNA repair gene, especially the RER pathway, that is ribonucleotide base excision repair pathway. The targeted genes here, usually the transforming growth factor beta gene and BAX gene. And whenever there is accumulation of this abnormal DNA repair gene, that causing the microsatellite instability. It might be germline, it might be sporadic. If it is germline, then it causes Lynch syndrome. Only these few points you have to remember. Okay. So it's basically an base excision repair mechanism is altered, which causing the microsatellite instability, and this accumulation of mutation causing that formation of again dysplasia and invasion and blah blah blah. And basically it causes, usually it is germline, usually it is sporadic, but in some cases it might be germline. And if it is germline, then it is associated with non-polyposis coli syndrome, that is known as Lynch syndrome. So, if it is germline, then it not only causes the colorectal carcinoma, but also causes the what? Endometrial carcinoma, ovarian carcinoma, biliary tract carcinoma, urinary tract carcinoma, etc., etc. Extra-intestinal, extracolonic manifestation. This part is difficult, I know. This part is difficult. That is why I am giving much time over there. প্রত্যেকে বুঝেছো প্রত্যেকটা পয়েন্ট? Have you got everything? এখনই ডাউট হলে বলো প্লিজ। Any doubt? Any doubt? Okay. Now the colorectal carcinoma proper. So what are the predisposing factors? Some factors are associated with the development of colorectal carcinoma. You all know that, like lack of physical activity, consumption of red meat, obesity, smoking, alcoholism, etc. These are very common factors which are important for development of any kind of carcinoma, isn't? Of course. And some factors are present which actually amalgate to decrease the procedure of development of colorectal carcinoma, like infusion of multivitamin, especially which contains the folic acids. Secondly, there might be some kind of NSAIDs and aspirin. Use of NSAIDs and aspirins also decrease the probability of the colorectal carcinoma. Third is postmenopausal hormone replacement therapy. Postmenopausal hormone replacement therapy also decreases the chances. Secondly, then fourth is calcium supplementation, some micro elements like selenium, and of course the good habit of having some fruits, vegetables, fibers, which we don't usually take, isn't? So these good habits actually amalgate to decrease the risk of colorectal carcinoma. The colorectal carcinoma accounts for at least 98% cases of all malignant cancer which are occurring in that region. Male-female ratio is like all kind of things which are bad for male is also bad for, that is usually it forms the norm that male-female ratio is 2:1, and distribution wise it is usually seen after the 5th decade, that is after the age of 50. এটাই বলেছিলাম না, usually by the age of 50 the familial colorectal that is FAP converted into any polyp which is associated with FAP, there is 100% chance of development of colorectal carcinoma. So that age is important, 50. 50 is very important. Distribution wise, most commonly it is seen at the site of rectum, followed by 25% cases in the sigmoid colon and the descending colon, followed by cecum and ileocecal valve, and 5% cases in the other region. Okay. Now this is very important. Before that, I have to describe these things. এটা বুঝতে হবে. So what are which portion is involved in right colon and which portion is involved in the left colon? Anyone? Which portion you will be termed as right colon and which is left colon? Up to which region? Right colon কতটা? বলো বলো। Hepatic flexure. Hepatic flexure পর্যন্ত right colon? Hepatic flexure. Sure. Right colon কত দূর? কোথা থেকে স্টার্ট হচ্ছে? Ileocecal valve থেকে, then 1/3, exactly 1/3 of what? Transverse colon. Yes, the junction between 1/3 and 2/3 up to transverse colon. Transverse colon is right, and rest up to anal region is left colon. Within the lumen of right colon, which kind of material is present? Is it solid or liquid? Mostly liquid. But after that, in the left portion, it is solid. So it's just a common sense. If there is any kind of liquid, lumen. Nothing present in the lumen which can obstruct any growth, any exophytic growth. So that growth will ultimately increase in size and that will cause an exophytic cauliflower like appearance, isn't? কোনো বাধা পাচ্ছে না লুমেনের মধ্যে, সেটা বাড়তে থাকবে। খুব সিম্পল। That is why any growth in the area of right colon should be an exophytic type, that is exophytic cauliflower type, and that will obstruct the lumen, that will present as a mass, usually at the ileocecal region. এখানেই না রাইট কোলনটা আছে, at the ileocecal region at the right flank, it actually appears as a mass, and actually it causes the obstruction of that gut because it is an exophytic growth. যখনই গ্রোথটা হবে তখন this fungating polypoid growth will ultimately cause an obstruction. In the other hand, in the left side, solid fecal matter is present that will hamper that exophytic growth proliferation. লুমেনের মধ্যে গ্রোথটা বাড়তেই পারছে না কারণ লুমেনের মধ্যে অলরেডি ফিকাল ম্যাটার আছে। Then how this growth actually increases in size? They will spread in the deeper portion. They will spread either circumferentially, পুরো গাটে চারপাশে বাড়ছে, or they will increase in the deeper portion from the mucosa to submucosa, then lamina propria, then serosa. Okay, and whenever there is some kind of circumferential growth, that will constrict that lumen and it will form a napkin ring appearance. This term is very important, napkin ring appearance, as if the growth is constructing the lumen. There is, of course, there is an obstruction, but this obstruction is not due to this exophytic growth, but due to the constriction formed due to the expansion of that growth. So, in gross, you can distinguishingly differentiate between the right and left colon. Right colonic growth will be some kind of cauliflower-like polypoid growth which is exophytic in nature, and that growth per se can obstruct the lumen. On the other hand, the left side of growth, that will form a constriction ring that is known as napkin ring, and that growth actually increases circumferentially and it will spread in the deeper tissue. There is nothing, any exophytic kind of growth. এই পয়েন্টটা বুঝতে পেরেছো? It's very important to differentiate. দুটো এরিয়ার দুটো সিকোয়েন্স আলাদা হবে। সো একটা কমন সেন্স থেকে বলো তো, পলিপ কোন এরিয়াটাই কমন হবে? রাইটে না লেফটে? রাইট সাইডে হবে। পলিপ থেকেই কার্সিনোমা গুলো হচ্ছে। আমি কি একটু আগে বলেছিলাম এপিসি মিউটেশন জিন এটসেট্রা হুইচ আর অ্যাসোসিয়েটেড উইথ দ্যাট Adenoma-Carcinoma sequence। তাহলে এই যে এপিসি বিটা-ক্যাটেনিন মিউটেশন যেটা বলছিলাম সেটা কোন সাইডে কমন হবে? রাইট সাইডে হবে। এক্স্যাক্টলি। Polyp are not so common in the left side, of course, and এভাবেই চিন্তা করে নাও যে microsatellite instability, those are usually present in the left side. Okay. Third thing, if it is an obstruction, then যখন এখানে যদি এই এরিয়াতে যদি কোনো ইরিটেশন হয়, if something is passing through that area, it will cause the erosion of the surface epithelium, isn't? It will cause the erosion, so it will bleed. So the most important symptom over there in the right side is bleeding per rectum. কেন হচ্ছে? It is very friable, and the fecal matter and anything is going across this growth, that will cause the erosion and that will cause the bleeding. So the most important not complication, of course this is might be a complication in the later stage, but the most important symptom is bleeding over there. Okay, taito? So the most important clinical feature over is parrectal bleeding. Keno hocche bujhte parle? Now on the other hand, now think that this is a constriction type of ring. Constriction type of ring. And the fecal matter cannot pass into the anal region. The fecal, you cannot void. So suddenly, jokhoni cancer hoy, it will not be a very long time procedure. It will be a very short time procedure. So suddenly there is a change in bowel habit. Age normally jokhon jemon voiding hoto, ekhon shebhabe voiding hocche na. You cannot defecate. You cannot empty your stomach. So that will cause alteration of what? Bowel habit. Why? Because there is any constriction. বুঝতে পেরেছো? So the most important symptom over there in the left side of colon is there is some kind of alteration of bowel habit. Okay? তাহলে তিনটে জিনিস কি বোঝালাম? One is on the right side there is some kind of exophytic growth. It is more common in case of APC mutation and beta-catenin gene mutation, and that Adenoma-Carcinoma sequence is very prominent in the right side colon. And the third thing is usually the most important symptom is bleeding per rectum. On the other hand, in the left side, ki tinte? It will cause a formation of napkin ring constriction. It will cause, it is due to that mutation that is known as DNA repair gene mutation, and thirdly that will cause what? Bowel alteration and bowel and bladder habit. এটাই বলা আছে এতটা জুড়ে। এটা বলতে হবে না, পড়তে হবে না, it is MD kind of level তোমাদের জন্য না, এটাকে আমি জিস্ট আপ করে বলেছি। So symptom কি হবে? Clinical presentation কি হবে? In the right side colon, mass in the right iliac fossa, bleeding per rectum. And of course, when there is bleeding, there is loss of what? Loss of iron folic acid. So it will eventually cause the iron deficiency anemia. Okay. And of course, there is any cancer, there will be some kind of anemia of chronic disease. So morphologically, two distinct type of anemia are usually seen. One is microcytic hypochromic anemia due to the loss of blood, gradual chronic loss of blood. So that will cause the iron deficiency anemia, and morphologically it will be microcytic hypochromic anemia. And if it is anemia of chronic disease, usually it is normocytic normochromic type. So anemia is a very evident feature in case of right-sided colonic cancer. Next, there will be some cachexia, anorexia, etc. These are very common features of carcinoma. And third is obstruction. Of course, obstruction will be there. In the left side, there will be the most important feature is change in the bowel habit. Change in the bowel habit. Okay. And often you will get the constipation. Eventually, it will erase the mesentery and the blood vessels in the serosal layer. Due to the erosion, some kind of blood that might be present in the stool, but this is not so evident because very occult blood is present in the stool. It is not such as gross bleeding, which is very evident in case of the right-sided colonic cancer. So occult blood, occult bleeding is present in case of left-sided colonic cancer. What are the modes of spread of this cancer? One is direct spread. I have already mentioned that circumferentially spread can be seen, or there might be spread in the depth of the tissue. Second route is lymphatic spread. Lymphatic spread is usually seen in in the area, initially in the regional lymph nodes, and then gradually with the higher stages into the pre-aortic, internal iliac, or sacral lymph nodes, etc. And the third route is of course the hematogenous route. Hematogenous spread usually seen the four common region, that is L2, B2, lung, liver, brain, bone. বলেই ছিলাম যে কোনো হিমাটোজেনাস স্প্রেডে এই চারটে অর্গান কমন থাকবে, L2, B2, lung, liver, brain, bone, and here ovary is very important. If it is bilateral ovarian metastasis, what did you call this? কি বলে bilateral ovarian metastasis কে? Colorectal carcinoma, gastric carcinoma ক্ষেত্রে Prunkenberg tumor. Yes. So hematogenous spread might be there. Other areas should, that is other mode of spread could be transleomic spread, drop metastasis, etc., etc., but you don't have to remember. Next is microscopy. 90% cases are adenocarcinoma, not otherwise specified, and 10% cases some special variants like mucinous carcinoma, mucin secreting carcinoma, signet ring cell carcinoma, medullary carcinoma, etc. Don't worry, I will discuss them in great detail in my practical class. আজ ব্যাকসিল আছে না, তোমাদেরকে স্লাইড দেখাবো এটাই, হ্যাঁ। And depending upon the grade means, sorry, depending upon the differentiation, it can be divided into 3 grades. One is well differentiated, one is moderately differentiated, one is poorly differentiated. Well differentiated usually 15 to 20 cases, so also the poorly differentiated, most commonly the moderately differentiated. Differentiation is present depending upon the morphology, that is how it simulates the normal morphology. কতটা নরমালের মতন দেখতে লাগছে ম্যালিগন্যান্ট সেলগুলোকে, মানে ম্যালিগন্যান্ট এরিয়াকে মরফোলজিক্যালি কতটা নরমালের মতন লাগছে। কি দেখছো? These are all malignant glands invading into the stroma. All neoplastic glands are lined by hyperchromatic dysplastic cells, that is pleomorphic hyperchromatic cells with opened up nuclei, anisonucleosis, etc. All kind of dysplasia present in lining epithelium. These are abnormal lining glands which has invaded into the stroma. This is nothing but adenocarcinoma. My favorite question, initial question, why carcinoma? Because it is arising from the epithelial lining. Why adeno? Because those malignant cells are arranged like the normal glandular structures. Okay, that is why adeno. That is why it is known as adenocarcinoma. There are some other types like medullary carcinoma, mucinous carcinoma, signet ring carcinoma. I am not going to discuss over here. It will be discussed in your practical. So what are the modes of investigation? One is for why I have to see this, because to know the extent of the spread, any kind of metastasis present or not, and of course some kind of evidence that could be present. So the investigation might be radiological, might be pathological. What are the radiological modes? One is CCT, whole abdomen and pelvic region, also to know the extent of spread, and also the MRI. MRI is very gold standard for any soft tissue extension, soft tissue diagnosis. We can do the chest X-ray only to exclude if there is any metastasis in the lung, and also we can do tumor marker. The most important tumor marker is carcinoembryonic antigen, CEA. In case of hepatic metastasis, in 90% cases, the level is more than the normal level is 0 to 4. Usually the CE level in case of hepatic metastasis is very high, that is more than 20 nanogram per ml. So it serves as a purpose of tumor marker in case of colorectal carcinoma. And last is the staging and prognosis. The prognosis is very important. Prognosis is very important portion of That is all we the consultant pathologists have to convey this to our oncologist or oncosurgeon. What is going to be the prognosis? The prognosis of any colorectal carcinoma depends upon 4 important points. One is extent of bowel involvement. Second is presence and absence of metastasis. Third is the degree of differentiation, that is the histological grade, and the location. Because right-sided colonic carcinoma is very bad, left side is relatively good. Left side carcinoma is relatively good. Right side carcinoma is very, very bad. Worse prognosis in case of right colonic carcinoma. There are 3 methods of staging. One is modified Duke method of staging. Another is, that is also modification of modified Duke, that is known as Ashlar-Polar staging system. This is nothing but the modification of modified Duke methods, but the most accepted method nowadays is TNM staging method, most accepted method. There are 4 stages in the modified Duke method, A, B, C, D. You don't have to remember, only remember the name, but you have to remember to some extent TNM staging. I will discuss it in my practical class. Next is management, that is the last part. Management could be the surgical management, radiotherapy, and of course the chemotherapy. So surgically you have to excise that mass, also clearing up the proximal and distal margin. You have to clear the adjacent mesentery and at least 12 lymph nodes, at least 12 regional lymph nodes, tier 1, tier 2, tier 3. The regional lymph nodes over the colonic area can be divided into, you all know I think, divided into 3 classes, tier 1, tier 2 and tier 3. You have to exenterate these lymph nodes, at least 12, that should be in 12 in number, because that is the norms that should be pointed in the TNM stagings. Second is, in case of higher stages, that is the stage 4, where only the palliative treatment is the only mode of management. In such cases, bulk of the tissue should be removed. This is known as the local excision or part of palliative treatment in the higher stages cancer. Second is radiotherapy, that could be neoadjuvant chemotherapy or even after the post-surgical radiotherapy. Some radiosensitizer can be used like 5-fluorouracil. Usually it is given at a dose of 45 to 55 CJY over a 5 weeks period. And the systemic chemotherapy, it should be based on the 5-fluorouracil, and after 2021, in case of metastatic carcinoma, capecitabine can be used. You will get that name, you will learn this in a great detail in your pharma.